Abdominal aortic aneurysms kill almost 15,000 Americans each year. If detected early, new minimally invasive surgical techniques can correct this dangerous condition. With us today is Dr. Russell Montgomery, and a noted vascular surgeon at St. Joseph Hospital in Orange. Russ, thanks for coming today.
Yeah, thanks for having me, Larry.
So, the word aneurysm, people just freak out when they hear that word. What is an aneurysm exactly?
It is an enlargement of a blood vessel. And it can happen anywhere in the body, but basically when a blood vessel becomes 1.5 times its normal size, it's defined as an aneurysm.
And the ones we're going to talk about today are in the chest or in the abdomen, or?
Yeah, the abdominal aorta. It's one of our most common aneurysms, and it's the one that frequently requires surgery.
What would be the symptoms if you're having an aneurysm? Are there any symptoms?
Mostly people present without symptoms, and the aneurysms are incidentally discovered. Somebody will go to the hospital, they'll have a test for, a hip fracture or a gallbladder evaluation, and the test will incidentally find an enlargement of a blood vessel.
So when you have symptoms, that means it's just about to rupture or does rupture?
Yeah, symptoms are a worrisome sign.
Yeah.
If people are having abdominal pain or groin pain, back pain, early satiety, which is just a feeling of fullness, that is an ominous sign, and what we worry about is that it's either rupturing or has ruptured. Is
the pain in the front or in the back or both?
I wish there was one way to describe it, because it can be described in many different ways. But it's severe back pain typically, but it can radiate, meaning move from the back to the front, down to the groin. There's various presentations of it.
So what would be the common causes for aneurysms?
Yeah, risk factors. Smoking is a big risk factor.
Big one,
yeah, high blood pressure. People who have a family history of aneurysmal disease have a high incidence of aneurysms. In fact, first-degree male relatives can have up to a 20% chance of having an aneurysm.
Wow, is that much? Wow.
Presence of peripheral aneurysms is another risk factor. High cholesterol. Males, interestingly, are more likely to have aneurysms than females.
Is that right?
Caucasians more than any other race.
So the risk factors for this are generally the risk factors for heart disease too, right?
Yeah, similar.
Vascular disease of any sort. So when you have this, say somebody picks it up on they have back pain, they have a CT scan. Is a CT scan the best technique, or ultrasounds, or what is the best way to detect this?
When somebody is found to have an aneurysm, then they go through the evaluation of looking at the aneurysm and seeing if it's important. As far as size, do we need to worry about it, or should it be observed? The first test that people undergo, which is the simplest, there's no radiation, it's low cost, is an ultrasound test. And that's a wonderful way to screen people or identify an aneurysm. It's a good way to monitor aneurysms once they're found. But the gold standard in looking at aneurysms is CAT scans.
CAT scans.
CT scans.
Now I see you have a device here. So I guess the game has changed now, because there's different ways of treating this. You have here the minimally invasive type of treatment, and it looks like it's a game changer, right, as far as the treatment of these things?
Yeah, the problem with aneurysms is that they're inside our body and they're down above our spine. So the issue is if somebody needs surgery for an aneurysm, how do we get to it? In the past, it's a big operation. We'd have to make an incision from the sternum to the pelvis, open the belly, eviscerate or move out all the intestinal organs, go back to the back of the spine, clamp the artery, cut it out, sew in a graft similar to this into the body, tie it to both legs,
wow, big
close
deal.
Everything up, and it's a big operation. It's a wonderful operation. It's time tested. There's 50 years of experience with this type of operation, and people do well once they recover from the surgery. But the problem, as you can imagine, is the surgery itself.
From it, yeah.
And recovering from it.
So what are these devices now? These are new. What is this?
So the game changer that you're alluding to is we now have a way to fix aneurysms less invasively. It's a way of remotely accessing the artery without having to go through the abdominal musculature and all the intestinal organs. And what it is, it's a stent. And if you can imagine the aorta being a pipe that's got an area of disease, what we do is we go inside of the pipe and we reline the pipe with these types of stents. They've got metal on them, and you can see the metal structures and the interstices of the metal, and it's lined with a fabric. that keeps the blood inside of the
So there's
stent.
two different sizes for you size those to the person, is that right?
Yeah, when we prepare anybody for surgery, there's a complex set of evaluations that need to occur. And if somebody has an aneurysm, we look to see whether they need surgery or not. Now, most people, fortunately, don't need an operation. People with smaller aneurysms tend to have a very low risk for rupture, so they don't need surgery. And I think the thing to remember is small aneurysms tend to grow very slowly and have a very low risk of rupture. But larger aneurysms grow faster and the risk for rupture increases. In fact, it increases exponentially. So when you get to a certain size, just a very small increase in the size of the aneurysm results in a dramatic
Risk going up.
risk for rupture.
So this is your device here.
Mm-hmm.
This is your minimum. So
Well,
how
this is one of many devices. And as you can imagine, if we tried to remotely place this into the arteries, it would be very difficult to get it into the body. But they've ingeniously created a way to compact this device into a very small delivery system, which we can place into the femoral arteries, which are down in the groin, and remotely access the abdomen or the abdominal aorta from the groins.
Just through a little puncture mark like we do for heart catheterizations.
Yes, 18 French or 12 French systems exist.
I have a pen here, 18 French, so this is actually half the size of a pen.
It's very small.
Very small.
It's really
That's amazing.
cool.
Let's see how you deploy this.
So this particular deployment system allows me to position the graft where it needs to go. And once it's in position, and we're using fluoroscopy and X-rays to look at things. And then what we do is we slowly unsheath this, and this flowers out, delivering it right into the artery of choice. Now, this is one of the smaller limb grafts, and you can see
Wow, it's pretty cool.
how it's delivered. And then we would basically take this and remove this, leaving the stent graft in position.
And that's the stent behind. So Russ, now that we've seen what you can do, what are the indications for surgery?
Symptoms, obviously, is a big indication. Anybody who's having pain, we look to operate. But in the absence of that, it really has to do with the size of the aneurysm, because size predicts rupture. It has to do with the patient's health. In general, there have been 2 level 1 studies that have said basically the same thing. For open surgery, surgery is most beneficial when aneurysms are larger than 5.5 centimeters.
Okay.
What's happened, though, is we've had the advent of this less invasive technology, and the death rate or the risk of the surgery is less. And so we are now intervening a little bit earlier for aneurysm repair if we're able to use this technology.
And just real quickly, do you put people on blood thinners after this, or what do you do for this?
Not necessary.
And are they in the hospital for a few days or just one day?
The difference between the 2 operations is dramatic. The open surgery, people will be in the hospital 5 to 7 days typically, and the recovery time is up to 3 months. For the endovascular repair, the hospitalization is overnight, and the recovery time is a couple of weeks. But there are some disadvantages to the less invasive repair. There can be continued blood flow in the aneurysm with the stent graft in place, so people need to be monitored. Sometimes the single initial procedure isn't the only thing that we have to do to repair the aneurysm, and secondary procedures are necessary. But in general, people do better overall with the less invasive repair as far as recovery and morbidity.
Russ, we're just about out of time. What are the screening criteria for this disease?
People over the age of 65 with strong risk factors for aneurysmal disease, such as smoking or a family history. People, first-degree relatives with a family history, should probably be screened at an earlier age.
Thanks so much for coming on. It was a great topic. I appreciate it very much.